Hello and welcome. In this video, we're going to discuss children and psychopharmacology. So, some initial problems with kids that utilize psychopharmacological drugs or whatnot to deal with their issues to help them with learning and behavior in the classroom, right? There's been a nationwide study of school counselors, and the majority of respondents were dealing with a significant number of students taking psychotropic medications. The majority of respondents had no training in psychopharmacology, and the majority of schools had no policies for handling students on psychotropic medications. So 50% of children meet the criteria for at least one mental health disorder, right? That's much higher comorbidity for children than adults. Rates of psychotropic medication for children are increasingly yearly, and there are forces in the U.S. that are pushing the medicalizing of mental or emotional symptoms. So again, that push for psychotropic medication for those with mental and emotional disorders is rising, right? Which can be problematic to some that don't have access to it or don't have education on it, or they're not provided the right tools to be successful with it. So, some advocacy questions that individuals, non-medical professionals that are dealing with psychotropic medication with children should ask are: why is the med prescribed? Is there a black box warning on the med? What is the recommended dosage for children? Do lab tests need to be done before and during medication use? What is contradicted with the meds? Who will monitor main and side effects? Are there cheaper generic versions of the med? Do I feel I understand the med's main side effects? Has a full assessment been done on the child? Are there explanations for the child's symptoms? Do I know how the child's family feels about medication? Has my role in this been made clear to the family? So, talking about developmental issues and dangers and differences between adults and children, right? So, dozens of lines of development due to body size, rates of medication absorption, children less able to accurately describe the impact of medication due to their ways of expression, relatively poor engagement among children, parents, and teachers when reporting on behavioral responses to the medication. Children and adolescents, there is a greater need to coordinate an array of mental health services. Children and adolescents can have extreme reactions to even death to psychotropic medication as a result of cardiac failure. So the effects on child's sense of self and self-efficacy. So there's been little research done on intrapsychic effects of psychotropic medication on children. In the medicalized model, behavior gets to the most attention. For example, ADHD in treatment, behavior is emphasized over academic performance, but in sense of academic performance, but in service of academic performance. I'm sorry. There's more to life than performance, right? So again, we just want to look at the kids' performance. We want to look at how they learn. We want to look at their environment. We look at the whole child, not just performance, because other aspects can be attributed to their performance. So the state of mental health services for children, right? So child psychiatrists placing a burden on pediatricians and other gatekeepers. Only 300 complete training each year, right? So very few get training on this type of medication and this type of development. It is projected that between 1995 and 2020, the need for child and adolescent psychiatrists will increase 100%. 50 to 75% of teenagers in the juvenile system have a diagnosable mental disorder. There are limited funds for graduate medical training in children and adolescent psychiatry. Almost no fee loan forgiveness programs. Few incentives to hire children and adolescent psychiatrists in public mental health programs. And 1 in 10 children supposedly suffer from mental illness severe enough to impair development. There are fewer than 1 in 5 children who need to get treatment for mental illness. This burden is awfully suffered by children with mental health and their families. It is a healthcare crisis in America. With diminished psychiatric and psychotherapeutic support for children and adolescents, the use of all types of psychotropic medication become from treatment of choice, even though the majority of medication lacks from FDA approval. So children on psychotropic meds, the general findings. Majority of users are off-label. Psychotropic meds account for about 10% of all medication prescriptions. Children are increasingly prescribed psychotropic medication despite lack of evidence on efficacy. Counselors are being asked to be more involved in medication issues. The non-medical mental health professional role, right? So med education, being an integral information broker, cultivating relationships with prescribing professionals, clinical judgment on severity of psychological distress, counseling to resolve intrapsychic conflicts related to medication. Counselors seek supervision to discern appropriately on medication issues, co-monitoring possible side effects, and monitoring compliance. So non-medical health professionals' role, right? What not to do. Counselors do not recommend specific medications of clients. We are not competent to prescribe medication or discuss the impacts of medication because, again, we're not medical professionals. Counselors do not discuss clearly medical questions, and counselors do not handle medication. Screen out children with transient symptoms and limited studies of children with moderate to severe symptoms. Use multiple informant domains and settings. Develop more better measures of executive function impairment. Monitor post-study impact on development, and collaborate with developmental experts in design of evaluation of studies. Right, and these are what's recommended for those pediatric psychopharmacological studies. So ADHD, the typical client is again the typical client is said to be Caucasian, male, ages between 10 and 14, probably taking Concerta or Daytrana, or Focalin or Adderall. So there's some differential diagnosis with mental health: ODD, optional defiant disorder, cognitive disorder, depression or bipolar disorder, tic disorder, anxiety disorder, adjustment disorders, and psychosis. So it's also the differential diagnosis also can be organic, elevated levels, lead levels, substance abuse, seizure, medication induced, frontal lobe pathology, sensory and learning development, or developmental disorders. Approximate 3.5% of children in the U.S. on stimulants. 46% of children with ADHD also have a learning disorder. 1 in 10 children in the U.S. diagnosed with ADHD, and about 50% of those on stimulants. Children on stimulants show improvement in parent and teacher-rated ADHD symptoms, but make little improvement in functional impairment. Stimulants are thus thought to be only one part of what should be a multimodal treatment. Stimulants do not normalize the ability to learn and apply knowledge. Academic underachievement and less than optimal educational outcomes seem to be the norm. These drugs are not cognitive enhancers. So the multimodal treatment of the study of children with ADHD, that it was based off 579 kids, 14 months of medication of or behavioral treatment, or the two combined. Medication management came out with better outcomes than behavior management and equivalent to be combined. With a 24-month follow-up, the drug therapy correlated with clinical deterioration. Continued drug therapy was correlated with mild deterioration, and stimulant initiation for control showed with clinical improvement. The 8-year follow-up, 33% were still on meds. 83% of that was stimulants. Improvement in general maintained, but group not normalized over 8 years. 30% still made for some forms of ADHD. Antisocial behavior present. ODD in 25%. Medicated kids did better in math and reading, but there was significant test score gap between them and controls. So stimulant mechanism of actions, right? So first messenger effects: amphetamines cause release of DA and NE from synaptic vessels. may reverse certain transporter molecules, similar to cocaine, but it's less potent, right? The NE agonists like Strattera inhibits the NE transporters. Um, Effects on academic achievement rarely maintained in studies outside of 6 months time frame. The side effects were insomnia, reduced appetites, stomach, headache, and dizziness. And finally, the other side effect concern was growth delays, newer evidence questioning the origin of delays, hepatotoxicity, and vocal and motor tics. So that concludes our talk about children with psychopharmacological or psychotropic medications. Please remember that it's really important that the assessment process becomes very important for us when we make recommendations to families, when we discuss medication with our families and the benefits of it or whatnot. We want to make sure we're asking the questions on trauma, especially in terms of ADHD. A lot of our students are misdiagnosed with ADHD because we never look at the impact of trauma. The symptoms of ADHD can look very similar to the symptoms of a kid that's experienced a traumatic event, right? So timelines on when the symptoms started and if the traumatic event happens or whatnot to with the children demonstrating those symptoms is really important, right? So we want to make sure our assessment processes create a clear clinical picture for our children before we make recommendations. And remember, we are not medical prescribers and we are not competent to actually speak on those matters or whatnot, but we can make referrals and advocate for our clients that may be in need of those services.